breaking barriers and bridging the gaps between patients and doctors. Welcome to Brainstorming with the Docs and your co-hosts, Dr. Glenn Harrison and Dr. Kolby Condos.
All right, everyone, welcome back to this week's episode of Brainstorming with the Docs. I'm Dr. Kolby Condos. My co-host, as always, Dr. Glenn Harrison.
Good evening.
How's it going?
Doing great. I'm sad for this one. It's kind of a spitball episode.
Yeah, I mean, when we were looking at things that we wanted to talk about, or things that I think more importantly is things that we commonly discuss, because I think a lot of times we talk about cases behind the scenes. We spitball with each other about what we think about particular cases, and I think that this is going to be interesting and applicable to a lot of people because even though you have a diagnosis, it doesn't mean that two individuals with the same diagnosis are going to respond in the complete same way.
That's exactly right. Exactly right. So just because, you have diagnosis X, but you find a friend that also has diagnosis X, and the friend has diagnosis X, but has, Y strategy, doesn't mean you're going to get Y strategy, or it's even going to help you.
Or it doesn't mean that Y strategy is going to work for you yet.
Yeah.
So if this is your first time listening or watching and you like what you see and listen to, then please hit like and subscribe and turn on notifications, because we're going to continue to roll out new content each and every week. And hopefully sooner than later, we'll roll something out that's applicable to you. So today we are going to talk about something that has been incredibly prevalent in both of our practices, especially recently, it seems like. And that is going to be, and I actually think we talked about this in a previous podcast, maybe not. But that is SIBO, or small intestinal bacterial overgrowth. And basically what happens, I'll give you like a brief rundown about what is SIBO, right? So it's just like the name sounds. It's small intestinal bacterial overgrowth. And what happens is when you have specific, a specific set of environmental factors or criteria, these bacteria that are normally in one part of your gut actually translocate through a valve and then get into a really nutrient dense area, and they absolutely explode. So they just multiply, and this can come with a whole variety of symptoms and presenting factors. So it can be something like alternating bouts of constipation and diarrhea. It can be, abdominal bloating after meals. It can be fatigue. It can be malaise.
Brain
it can
fog.
be indigestion, brain fog. There's 1.5 million things that it can be, but that's the basic
high level understanding of SIBO.
Yes. So when you look at how it happens, there's a couple of things that you need to consider. So it could be, there's a variety of factors. None of these are concrete and bulletproof. In fact, most of the time it is one or more of these particular factors that lead to the diagnosis of SIBO or the development of SIBO. So when we look at it, it can be something like, failure of your gut to perform appropriate motility, which could be secondary to something like, chronic constipation, or it could be, suppression of certain reflexes. It could be a concussion. It could be a lot of different things like that, but that is one. So you're no longer moving the bolus of fecal matter and stuff through your gastrointestinal tract at the appropriate rate. So number one. Number two, and this one's really common that I see in my practice as well, and maybe you can correct me if it's not what you see, but secondary to antibiotic use can be a really big one, because antibiotics are amazing, but they don't just kill bad bacteria. They also kill good bacteria. So in a lot of cases, you can see this as kind of a rebound side effect if you have prolonged use of antibiotics. What else?
Well, those are, a big one. If we're kind of talking, kind of what you're getting into is susceptibility of SIBO. Is that what you're saying?
Yep.
Yeah, I see another one, antacid use. So people are taking a bunch of antacids because of heartburn, indigestion, etc., over the counter, prescribed, and there's reasons for all of these things, and but that changes the pH of the environment, and it allows certain bacteria to flourish and some bacteria to not flourish, and then you end up with this a disruption of the balanced ecosystem, and then SIBO can be a product of that. Antacid use, but it also could be anything that causes acid reflux anything that causes an inhibition of acid. And we've talked about this before. Podcast is heartburn, I believe. I think we did. So anything that disrupts acid, it could be diet, it could be stress responses, it could be autoimmunity, anything that suppresses stomach acid. And how do you know if your stomach acid is suppressed? If you have a history or a diagnosis of acid reflux, a GERD, all this sorts of different names for the same reason, that any of those symptoms, heartburn, all of that is an indicator of low stomach acid. Low stomach acid changes the environment, and then this bacterial problem has the opportunity to exist. So the acid piece is,
right?
Yeah, the acid piece is a big one. Autoimmunity is a big one, but that's, secondary to acid. And then the acid is, I have secondary, I guess, or a trigger for the SIBO. So I guess what we're trying to establish here is many different causes for SIBO. Don't just take this pill and it'll fix it. Don't take this fancy antibiotic and it's going to fix it. This amazing diet is going to fix it. There's mechanisms of it. So the kind of what we're going to get in.
The problem is too with the get quick, get better quick with the pill or whatever, is that more often than not, if you don't address the underlying factors or the underlying cause, it's going to come back.
It'll come back, and it probably going to come back with it. Right? Yeah, probably going to come back even more aggressively because there's more and more time that it hasn't been fixed, and it had the opportunity to change the environment. The SIBO changes the environment even more, makes it more stubborn, or permanent neurological injury. So the neurons or the nerves wrapped around the intestine stretches enough, it creates damage to the nerves. So you can have a permanent neurological disorder. So long-term SIBO is never good. So, that maybe that kind of segues us into what we're going to talk about today, which is cases.
Right.
So I'll touch on a case because it plays right into this. So permanent neurological disorder. So there was this lady, she was this was years and years ago. She was in her 60s, I guess, early 60s. She came in and she had constipation. Okay. There's one red flag, right? But her concern was really some stomach discomfort and some foggy brain. This was her concern. And she didn't know anything about the SIBO world or anything. So she came in, she had those symptoms. We did an exam, found out that, oh my goodness, there wasn't any vagal nerve stimulation. There was from the brain. We weren't seeing it when we looked in her mouth and do the ah reflex, all of that. There wasn't enough vagal nerve input that should be on its way to the gut. It wasn't hitting the oral cavity. At least we weren't seeing the upper palate. So we weren't getting brain firing to the gut, as you talked about before, Dr. Kolby. You're not getting, you could be at least speculate that there isn't enough neural input to move food through the intestine because it's all a brain function. So I'm like, wow, that's not good. So I asked her about bowel movements. Well, she was having one bowel movement every, 3, 4, 5 days, and her stomach would be achy. She was a vegetarian for years and years and years and years. She had, again, serious balance issues. No reason for that. Brain fog, fatigue, concentration difficulties. She was already retired, so she didn't have any significant cognitive challenges with work anymore, but it was a challenge at the end. She just wasn't feeling good, lethargic. Brain wasn't working. So we found this out, and we knew there was constipation. Did an exam. Her stomach was loaded up with gas. It was locked right up. A lot of pressure in the upper abdominal cavity when we're palpating. Like, this isn't right. Do you have a bowel movement? No, it's been a few days. Well, that's not good. What's the source? She's eating a great diet, a plant-based diet. So what did we find? What was the overall case workup? Well, we speculated SIBO. We didn't even do a test on it. There was no H. pylori, which is can't get into all of the mechanisms, but she was constipated. She had a good diet, relatively good diet. She was not a junk food vegetarian. She was a real vegetarian. She had brain fog. Then we found out she was severe hypothyroid. So that had to get managed. So the thyroid is one of the hormones, if we want to simplify it, to stimulate gastric motility. So that was another potential reason why she wasn't moving food through and producing enzymes and breaking down fibers. So now the SIBO bacteria climbed up to the smaller intestine because food was moving through slowly. and there's lots of plant fiber, and Sibo loves plant fiber. So that wasn't good. And then a low thyroid slowing down brain function, further not getting the vagal nerve input in theory. So the thyroid was suspected it was part of it. And there she was. And we're talking 30 years of this, 30 years of it. Okay. All of our life. So where did we start with that? Well, we made, diet, nutrition, referred her out for thyroid medications, got the thyroid dialed in. That helped out greatly. Had to modify the plant diet. She still did it, but she was a trooper. We had to change diet to help reduce the effects of Sibo. Ultimately we had to supplement all the things that are her own digestive organ system should have been producing, the enzymes, the acid, all of these things. We're trying to do that because her brain wasn't able to stimulate all of those. Well, she started to have bowel movements. That was a win for me. She didn't really think of it because her stomach was sore, but over time it started to improve. Her brain fog started to lift. The diet sucked, right? The diet sucked. The supplements weren't fun, but she did it all. She had, she felt better. She was functioning, more energy, more brain function, all of these other things. However, 30 years of Sibo, the pressure on the intestine so much, injuring the nerves that are wrapped around it intricately. And I did an article on this. It's on the website. So if anybody's listening to this, it can read the article. The nerves wrapped around delicately around, and this is your world, Dr. Kolby, I'll let you fill in, but it wraps around the intestine, and the intestine stretches enough, can create a mechanical injury, and there's probably other mechanisms of it. So then you might have power coming out of your brain going down so far, but if the wires are broken, you're not getting power to the intestines to create gastric motility or gastric movement. So we did all this and she was doing great. And I was like, okay, now we're going to reintroduce some food so that we can have more diversity in the plant diet. She couldn't. Surprisingly, she was able to introduce about 30% of the foods that she needed and, get off, 80% of the supplements, but she couldn't get off 100% of the foods. And I believe she had permanent neurological damage from 30 plus years of Sibo. I truly believe it. That's the worst case I've ever seen with Sibo, and I've seen many of them. So that's
could have been, right? When you look at, we talked about positive and negative neuroplasticity, but then on top of that, when you look at when there's actual insult or injury to nerves, you can go through the denervation process, right? So if those axons aren't being used or those, those specific pathways, they will actually denervate and they'll shrink and die. So not being utilized, being injured over and over and over again. The stretch response isn't working anymore. So definite possibility. I also think that it's funny, and I'm going to highlight this a little bit, because when you were talking through this case, it's a Sibo case, right? But then we also look at the hypothyroid issue. So again, you just kind of made the point where just because you have a diagnosis, they are not all the same. When you look at the concomitants that are integrated with all that stuff. So a person that has hypothyroidism and Sibo is not the same as someone who has a traumatic brain injury.
That's a great example. That's a great example. So she never had a history of any kind of traumatic brain injury in the case workup. And so, I wasn't, why is there no vagal nerve input? Lots of reasons, but it wasn't due to trauma, at least in the history. So I wasn't going to chase that down. But then with proper lab work, we found, metabolic hormone, a very important metabolic hormone like thyroid is slowed right down. So, this same individual could have went to, somebody who's not looking at labs, somebody who's not looking for, for these kinds of things, say just nutrition. Well, how far would have they got?
Right. Especially when that thing that's slowing everything down is not being used.
Maybe would have never got any results.
Yeah.
So, there's, they're trying to look at the whole story. So that's, I guess, the purpose of this episode. So you probably have a few cases. Do you want to throw one?
Yeah, I do. So I have two that kind of came to mind when we were spitballing this idea. So I have two, both of them are males. Both of them are in their 20s. One of them, both of them have history of traumatic brain injuries. Both were really good athletes. But I have treated them and helped them manage this completely different. So the one patient, because it was so severe when we ran the blood work, and I actually ran like a stool sample test to check what the bacteria were, what the specific strains were, and all that kind of stuff. complaints of like chronic depression, anxiety, fatigue, like severe nausea when eating, bloating, all this kind of stuff. Okay. The other one, same thing, history of brain injuries, bloating, weight gain, brain fog. But his main complaint when he first came were actually vestibular complaints. So got the vestibular complaints taken care of for the most part. But I mean, and this is also, I had this conversation with this patient today where everything is so integrated in the brain and with the gut. You can actually increase the frequency of firing to your gut just by doing like specific vestibular movements. So like spins and stuff like that as well. So the way that I treat both of these guys and help these guys manage their symptoms is completely different. I put one on a complete food restriction diet because he's far away, right? So I put him on what's called an elemental diet, where we basically remove like all the foods and we put him on like a powdered
anything diet that the bugs can eat.
Anything, right? We're starving them. Then we're going to do a supplement schedule with him. So we're going to give him some supplements, help him kind of get rid of the bacteria, and then we're going to slowly introduce different foods. Mm-hmm. The other guy we do a bunch of vestibular rehab with, and one of his main concerns was he actually had low stomach acid. So we're actually getting ready to do a endoscope with him to make sure, but we suspect really strongly this is a big case with him because he's got chronic heartburn, all this kind of stuff. So even though same diagnosis, different management strategies because they're individuals, right? It's not, we're not treating the condition. We've done podcasts on managing, you manage people, you don't manage conditions, right?
Yeah.
And it's because everyone is unique. Everyone's lifestyle is different. All the precursors or the predisposing factors are different amongst individuals. So you can't just say, oh, you have this, we're going to give you this. So I think that's the biggest takeaway for me, at least when we were talking about this, because I mean, we talk about this stuff all the time. Like, hey, any ideas on maybe some strategies for this? And it's like, well, I mean, it really kind of depends.
Yeah, that's interesting when we talk about this, if we're texting or whatever, but like, hey, XYZ, where do we start? Well, first thing we both want to know when we're being asked this, okay, what's the story? Where are they coming from? What are their complaints? What do they look like? Are they stressed? Are they anxious? Are they happy? Are they relaxed? Are they sleeping? Like we're not.
Are they compliant? Are they going to do what you tell them?
Yeah. The first questions are not what's in the blood. It's like, who are they?
Yeah.
What do they look like when they're coming in?
Yeah.
Deeper 100%. Questions are, okay, what does the blood look like? So, and then down the road is like, what are the diagnoses?
Right? Yeah, absolutely. And then the question is, do we really care? I mean, you care what the diagnosis is, but it's kind of like the whole diagnosis audiosis. Well, this is what you got. See you later. Like, good luck. Yeah, no, yeah. I could care less about like, yes, we found the diagnosis versus, okay, we know what's wrong. We know what's not working. How can we get to a place where it's working better and you are feeling better? Mm-hmm. Right. So that's the biggest thing. Yeah. So the big takeaway from this is like, even if you have the same diagnosis as somebody else, just because you have that doesn't mean that the management options are completely the same. This is where having care tailored to you is really important because, like I said, both these guys are in their 20s, right? They both have the same diagnosis, but the onset of them is completely different, right?
Yeah, and the mechanism.
The initial cause of the SIBO is completely different. That's and their complaints were completely different. The one guy's like, yeah, my stomach hurts really, really bad. And the other guy's like, I'm super anxious and my stomach hurts when I eat stuff and I feel like I can't go to the bathroom very well.
Yeah. So SIBO shouldn't be the focus. SIBO should be seen as a symptom of all sorts of things happening the wrong way. And then SIBO is just a symptom, a product of the dysfunction. So you find the dysfunction and correct the dysfunction, the resulting product of SIBO should dissipate.
Right. Then you find, like you said, you find the issues and then you address them, whether that's vestibular input or whether that
thyroid
is
function,
stomach acid or metabolic hormones like thyroid or dietary, whatever. You figure out what the triggers are. You figure out what the predisposing factors are. You mitigate some of those, and then that's when the relief starts to come.
Yeah, you really need that guide because it's not common knowledge for someone unless they're living the lives that we are, that are kind of, up to our elbows in it every day. But anyhow, so I guess that's That's our Sibo cases.
That's it. There you go. So if you like this format, if you want us to break down more cases, if you guys have your own case, that you're interested in,
that'd be good. Yeah. And willing to share it, be more than happy to kind of spitball it together and then see what we can brainstorm on the case.
Yes. But you guys can always get a hold of us. Our email associated with the podcast is info@brainstormingwiththedocs.com. We both have websites. Mine is northlakescheropractic.com. Dr. Glenn's is drgharrison.com. We're on YouTube, Spotify, all the spots. So,
yep.
And if you, or just ask a comment in the question or a question in the comments, and we'll get back to those as well. And stay tuned, because we're going to continue to roll out new content each week, and hopefully we have something that's applicable to you.
All right. That sounds good. I look forward to the next one, Dr. Kolby.
All right, buddy. Have a good one.
Bye-bye.